Morning, everyone. Welcome to the course on diagnosis and management of localized, locally advanced, and advanced kidney cancer. I'm very thrilled to welcome to the people here in the audience, and they tell me a huge group of people watching this virtual. We're thrilled to have you, and I'm thrilled also to have my colleagues, Dr. Martin Ball from the National Cancer Institute. I'm going to talk about genetics of kidney cancer and about how that affects your management, your surgical management of patients with kidney cancer. Dr. Ball is going to talk about many of the advanced aspects of surgical management of kidney cancer. We're very thrilled to have Dr. David McDermott, one of the leaders in the field, from Beth Israel Deaconess Medical Center, Dana-Farber Harvard Cancer Center in Boston. Obviously, is going to talk about some very exciting new data on management of advanced forms of kidney cancer, and he's going to be primarily focusing on clear cell renal cancer. And we're also very, very happy to have another leading expert in the world on this, Dr. Ram Srinivasan, again from the National Cancer Institute, who's a medical oncologist, as is Dr. McDermott, and who's going to talk to us about management of non-clear kidney cancer that's advanced, and also going to give you some very exciting, up-to-date information on drugs we may use to treat localized disease in patients with VHL targeting HIF2. So we're going to hear about those things. I'm going to start then. Are we doing the questions now, or am I going into my talk? Okay, just keep going. Okay, all right. Okay, here we go. All right, so we're going to do a poll test, and we'll do this before the session. We'll look at questions, and then we'll do it after as well. And the way you respond to this is with your cell phone. You text to, and anybody who's got any questions, she's here in the back in the blue shirt, can help you with this. You text to 22333. That's 22333. And you put in the body the message K Johnson 080. That's K Johnson 080 in the text, and you'll get back the poll. Okay? All right. So she can help anybody. Just raise your hand, and she'll help anybody who's not square. But this time, most people are pretty cool with it. So I'll just give you a little quickie test here. So this is just a test to see if you can get the system to work. And what do you like most about New Orleans? You know, A, AUA, of course. B, Creole Cajun food. C, the French Quarter. Or D, Bourbon Street. I'd go for D. What we have some results coming in here. So we'll go ahead and go through this. So here are most people like Creole and Cajun food. Well, my mom would love that, being from New Orleans. So, okay, so I think you've got the system pretty well worked out. So, okay, so now we're going to go to the actual pretest, and we're going to do some questions here. And the first one is the recommended surgical management of a 26-year-old patient with VHL von Hippel-Lindau with bilateral, multifocal, clear cell renal cell carcinoma, the largest which is in the right kidney, is 2 centimeters. So patient VHL clear cell, largest tumor is 2 centimeters. So how do you manage that? VHL clear, 2 centimeters, right nephrectomy, bilateral nephrectomy, these people get tumors on both sides, right partial nephrectomy, or active surveillance. Okay? So that'll be question pretest 1. Okay, we'll go to question number 2. All right, now, tumor enucleation. So you got a patient with renal cancer, tumor enucleation, as opposed to wide excision partial nephrectomy, is best suited for a patient with multiple comorbidities and a small renal mass. So tumor enucleation, just take out the tumor. What's it best for? Multiple comorbidities, a small renal mass. B, a large renal mass where biopsy suggests high-grade features. Multiple renal tumors. Or D, an infiltrative renal mass. Okay? Enucleation versus wide on the partial. How would you handle that surgically? Okay? All right. So we'll go to the next test, number 3. All right, so that's a good one. Lymphadenectomy for RCC is best indicated in which of the following scenarios? So lymphadenectomy, When do I do lymphadenectomy? Good question. For all patients with C2 or greater tumors? At the time of radical nephrectomy? Okay, got that. With renal sinus fat invasion? C, for a patient with enlarged interaortal node? Or D, for a patient with biopsy-proven papillary type 1 RCC? So when do we recommend lymphadenectomy? All patients, TC, radical nephrectomy, enlarged nodes, or type 1 PAP? D. All right, let's go to 4. Okay, so up front, cytoreductive nephrectomy, that's a good question. When we see patients come to us, metastatic disease. Up front, cytoreductive nephrectomy is a treatment option for patients with A, small volume metastatic disease, all right, cytonephrectomy, small volume, okay, that makes sense. IMDC, poor risk, metastatic renal cancer, that'd be a good one for this. Low performance status, metastasis involving multiple organs. The patient comes to you, as it makes sense to do cytoreductive nephrectomy in which of these following scenarios? Okay, all right, let's go to pretest number 5. In patients with kidney cancer, response to PD-1, so that's IO therapy. We're seeing a whole lot of that, obviously. In patient, if one of your patients has metastatic disease, response to therapy with an immunotherapy targeting the PD-1 pathway blockade, you know, these are a whole lot of these agents, and very exciting, have been associated with which of the following? Response to PD-1. Okay, which of the following? Is that if we sequence it in tumor mutation burden? Is it those that have sarcomatoid histology? Sarcomatoid, okay, are they more likely to respond? We're hoping so. Is it if their T effector gene expression is up? Or the last one is the PBRM1 gene, which is on chromosome 3, next to the VHL gene. Is that the answer? Number D. Okay. Okay. All right. So, next, I'm going to start with, again, the genetic basis of kidney cancer, why this is important to you and me as urologic surgeons in our management of our patients. Now, when we started our work on kidney cancer, 3.5 decades ago, kidney cancer was a single disease. We treated them all the same surgically, gave them all the same drugs, none of which worked very well. We now know that kidney cancer is not kidney cancer. It's made up of a number of different types of cancer that just happen to occur in this organ. Different histologies, you can see here. Different clinical course, responding differently to therapies, and as we now know, caused by different genes. We now have 18 different genes that cause kidney cancer. So kidney cancer just happens to happen in this organ, 18 different types of cancer. And most of what we've really learned about the genetic basis of it comes from our study, the study of patients with hereditary or familial kidney cancer. This is much more common than people thought. And we now know there's at least 14 different types of inherited kidney cancer that you'll be seeing in your office if you manage kidney cancer. And those are the genes that cause those 14. Now, why do we care as urologic surgeons about the genetic basis of kidney cancer? I'll tell you why. Because it'll make you a better surgeon and a better clinician. There's no question about it. So in other words, and you're going to hear a lot more about this from myself, Dr. Ball, and the other speakers. In other words, if you have a patient and you know the genetic basis of it, should I do active surveillance, watch this tumor? There's a lot of people doing that. Or should we do surgery now? Also, what kind of operation should I do? Robotic versus open? Should I enucleate? We'll hear from Dr. Ball. Should I go wide on my margins or enucleate? How should I do this surgery? And should I do active surveillance on this, or should we treat this patient? If we treat, and you're going to hear a lot about this from Dr. McDermott, Dr. Srinivasan, agents that target the VHL, HIF, VEGF pathway, that target the MET pathway, another cancer gene, kidney cancer gene, the FH pathway we'll hear about, or should we give them, these immunotherapy drugs, PD-1, PD-L1, CTLA-4, we'll hear about that. So we're going to talk briefly about 4 different types, histologic types of kidney cancer, and just give you a little overview, a brief overview of how we might think about managing these individually that are different from each other. So we'll start off with the most well-known type of inherited kidney cancer and what that's taught us about how to manage regular non-hereditary, most common type of clear cell kidney cancer. So we'll start with this patient, 29-year-old female, appears to be affected with von Hippel-Lindau. She comes for initial screening. She hadn't seen doctors, whatever, this happens all the time. She does have cerebellar hemangioblastoma, had surgery, and now she's come to understand she has something in her kidneys. How do you make that diagnosis? Well, it's really simple, and I'm going to say the same thing about all these. Really simple. All you have to do is order a panel. All right, so a panel of kidney cancer genes, it'll have 18 or 19 genes in it, and you can also throw in some DNA repair genes if you want, but you don't even have to remember the gene names. Just get a panel. All sorts of companies run these. They're not that expensive. Insurance generally will cover it. So this disorder is caused by an abnormality of this gene we call the VHL gene, all right? And they're 100% so far, 443 families. We're now up to 443. 443, we found mutations. So it's basically a very, very accurate test, easy to do, and not that expensive anymore, fortunately. So this patient had positive tests for that. You can see on this screen what that gene was. And she has these tumors in her kidneys, all right? So she's got a number that are, she's got 1 centimeter, a couple that are 2, a couple that are 1.5, and one in the left kidney that's 3.5 centimeters. So how do we manage that? Do we watch it? Do we operate? Do we need a nephrectomy, bilateral nephrectomy? What do we do here? So we've learned over the past 37 years in managing patients with von Hippel-Lindau and many, many surgeries and surgical approaches and working on this. This is always clear cell renal cancer. We don't say always often in our field, but this is always clear cell. Over the years, we developed a surgical management approach where we recommend active surveillance, not doing surgery, active surveillance till the largest tumor reaches the 3 centimeter threshold, at which time we recommend surgical intervention. In 37 years, 1,254 patients, not yet, we made more of it, as of today, not yet had one patient develop metastatic disease. We've had 53 of our patients develop metastatic disease, but had larger tumors. Not one yet with 3 or smaller. So that's what we recommend for this, and 2 others I'll show you, but very differently for other types of kidney cancer. Here, she had a left robotic by Dr. Ball, left robotic partial nephrectomy. Actually, this was prior to Dr. Ball, but 54 lesions were removed, 33 cysts were taken out. These were all ISUP2, so you and I would say Furman 2. It's now ISUP2, and patient has done very well post-op. Now, how do we do these procedures? What do we recommend? We recommend enucleation, all right? Now, we've taken out as many as 93 tumors from a single kidney, and one of the fellows not too long ago took out, I think, 51 or something. But we are very careful about this, and you'll hear about this from Dr. Ball. We do enucleation. So if we're taking out a bunch of tumors, you can't take big margins on these, and we've done very well with this. So that's our approach for VHL, clear cell VHL mutation, kidney cancer. So that's the first base. All right, so here's the second one. This one has no family history, has one kidney, one tumor in the kidney, has a 3.3 centimeter mass in the left kidney. Okay, well, we decided to biopsy this. So he had a biopsy, and then surgery, had a nucleation. This was a clear cell renal carcinoma, Furman or ISUP2, in other words, low grade renal cell cancer. And actually, a good question for Dr. Ball on this one, I want to ask him this, is, I know what he did here, but how would you manage these going forward? What do you recommend to people who biopsy something, they know it's clear cell, maybe they even know it's a VHL mutation. Do you enucleate here? Do you go a little wider? So we'll get that for him during his talk. And this is sporadic, non-inherited clear cell kidney cancer, VHL mutation in over 90% of these tumors. Now, here's the third case. So this one shows up, sadly, with a larger tumor. Again, biopsy here showed clear cell renal carcinoma, higher grade, and sadly, this patient presented with metastatic disease, big mass in the retroperitoneum, and also disease in the neck. So what do you do here? And we'll talk about that more. When do you resect? When do you go after locally advanced disease? And how do you think about treating these systemically? And we're going to hear a lot about this, but basically this pathway, we and others, our colleague Bill Kalin at Harvard, obviously huge in this, have described this pathway. We know that the VHL gene, product of the VHL gene, targets something called hypoxia-inducible factor you'll hear about, or HIF, normally for degradation, and when it's mutated in the cancer, it can't, and HIF goes up, and that drives a bunch of things you and I know means cancer, like blood vessels and local growth and all that. And this provided the foundation for the development of drugs targeting clear cell kidney cancer, the understanding of this pathway. The FDA has now approved 9 drugs that target this pathway, and we're going to tell you, going to hear from Dr. Srinivasan about the 10th drug that was just approved for VHL kidney cancer. Big studies going now with sporadic kidney cancer, targeting the HIF2 pathway in VHL, which we think is the most critical pathway, and you'll hear the work about the HIF2 drug belzutifan in patients with VHL. So that's clear cell. How about non-clear cell, right? We say clear cell is about 75% of kidney cancer. What about the other ones? They sure seem, well, we sure see a lot of them. So this is a patient that we saw had multiple tumors in both kidneys, bilateral, multifocal. And this was type 1 papillary kidney cancer. He also had a family history of kidney cancer, many people in his family. Just kidney cancer, didn't have anything else like brain or tumors or theos or something like that, just had papillary kidney cancer. We called this hereditary papillary renal carcinoma, HPRC, familial form of type 1 papillary kidney cancer. Well, over the years, this is, I think now 27 years actually, we've developed a surgical approach managing this, same way as VHL, where we manage these conservatively with active surveillance till the largest tumor reaches 3 centimeters. And again, as of today, in 27 years, we've not had one patient develop metastatic disease when managing that fashion. We have had a number, sadly, come with larger tumors, develop metastatic disease. This is cancer, but not there. So that's how we recommend managing these. How do you make the diagnosis? Again, just do a panel of kidney genes. It's a family, it's bilateral. We recommend genetic testing for people who are under 46, people who have bilateral multifocal, and people have a family history. So it's easy to remember, it's easy to get the test. This is one of the genes MET. So that's the gene for hereditary papillary renal carcinoma. Now, how about this patient? This is a 55-year-old who we saw with bilateral multifocal disease. He came with this. And again, this is one Dr. Ball operated on. You can see this patient had bilateral multifocal disease. On the largest on the left is 4.8 centimeters. We don't like that. On the right, it's 4 centimeters. We biopsied this. It was type 1 papillary renal cancer. Okay, BMF, we did a panel. It was negative. Exactly. This is bilateral multifocal disease. That's much more common than is hereditary papillary. We manage those the same way. So he had bilateral partial nephrectomies. This is a young woman who came with this large cancer. It was papillary. We found it to be an unusual type of kidney cancer. It was actually novel when we found it. And that's something called TFE3 kidney cancer, which is a type of papillary kidney cancer. When your pathologist will stain those cells, it'll come up positive for TFE3. And if they're not sure, it's kind of a funny papillary, maybe clear papillary, say stain for TFE3 kidney cancer. And also the staining, if it's a little iffy, ask them to do a FISH test, It's easy to get, it's the gold standard, and it will tell you 100% if this is what you call a fusion kidney cancer. You might say, well, it sounds pretty unusual, but it's not as unusual as you think. Also, here's one we saw, a 23-year-old who came up from the South. She's a law student. And she had this 2 centimeter lesion in her left kidney. And she presented with positive node. So this you do not do active surveillance on. This is more common than you think. 40% of kidney cancer in children and young adults. A young person with kidney cancer under 46, think fusion, think TFE3 or TFEB. You could even see it in adults. It's about 12% of type 2 papillary. We do not recommend active surveillance here. This is the last one I'm going to go over. And this is this patient here. Oh, she was 24. She had this cyst in her left kidney. We weren't sure. Was there something else there? On CT, we weren't so sure. We did MR and we saw this. She's 24. We said, oh my word. She also had a skin bump, cutaneous leiomyoma, and she had early onset fibroids. We said, oh my, this must be HLRCC. We did germline testing. It was positive. Another one of the tests on that panel for FH gene, fumarate hydratase. She had a family history. You can get cutaneous and uterine leiomyomas and kidney cancer. The gene is fumarate hydratase. We and another group helped characterize this. This is highly effective, 98%. We have 764 patients with this, and we're 98% positive on this germline test. So how do you operate on this? We went wide, I mean wide on this, almost all the way to the collecting system with this one. It was tumor inside the cyst. Also, it invaded through the parenchyma. This is the patient we saw, this guy and his family, actually. This is a 52-year-old, had bilateral multifocal, these small lesions you see. We took this out. You can see we go wide on this. We looked at that, and my word, it had already gone through the capsule and was invading into the parenchyma. If you'd done our standard enucleation, not good. You spilled these cells, that's trouble. This was his 17-year-old daughter. She shows up with this. Left kidney, you can see there at about 3 o'clock. In red is one lower, about 6:30. These came out. Look at this. Our pathologist about fell over dead. She said, Marston, you're not going to believe this. This tumor, this little 7-millimeter tumor, has gone already through the capsule, and it's invaded up into the parenchyma. I said, don't tell me we've got a positive margin. No, she no, you went wide on that. So this is a guy, came with a cyst, a small tumor, inside cyst, positive node. These can spread when they're small. So you don't do active surveillance. This is a lady that was going to get screening on the outside. We saw her in 03, and then she didn't. 3 years later, she got screening. They called this negative, but we look real close. It's easy in retrospect. Maybe a lesion there. 4 years after that, they called me and said, hey, we got one of yours over here. It's over in a city near ours, and yeah, she had this, that. 10 of 59 nodes were positive. We lost her 2.5 years later. So we do not do active surveillance on these, and imaging every single year. So what I've showed you is kidney cancer is not a single disease. Different histologies, different clinical course caused by different genes with different clinical approaches. And you use a precision surgical approach. Some you manage, some you do surgery. Some you do enucleation, some you go wide. But understanding the genetic basis of this disease will make a big difference. Thank you very much. I'm happy to welcome to the podium Dr. Mark Ball. He looks good, but he should be a little exhausted. This is his third educational course at this meeting. Dr. Ball.
Good morning, everyone. It's great to see so many faces in person. This is the third time we've given this course, but the first time in front of a live audience. So it's certainly great to see some familiar faces in the audience as well. Pull up the slides for Mark Ball if you can. So my task this morning is to really talk about sort of two bookends of surgical management of kidney cancer. And that is how we do partial nephrectomy, and then on the other end, for advanced disease, when to think about cytoreductive nephrectomy. Bear with us for just a moment. Yes. Okay.
If you can present.
We can try that. One moment, folks.
1 second, sorry.
right, everyone. Here we go. Okay, no relevant disclosures. So again, how do we think about partial nephrectomy, and how do we think about cytoreductive nephrectomy are the two considerations for this talk. So let's start with partial nephrectomy. So this is a case that I saw about 18 months ago. This was a 71-year-old man who was referred to us with bilateral renal masses. He did have a genetic workup since he had bilateral masses, but it was negative. He actually, before he saw us, had a biopsy of the right kidney, the smaller tumor, but a little more central, that showed clear cell, RCC, no Furman grade was given. The left was not biopsied. He had good renal function. His creatinine was 0.9, and he had an eGFR of 79. So this, he was referred because nephron sparing surgery was needed for someone with bilateral renal masses. So how do we think about that? And when I think about how to do a partial nephrectomy, I really have my decision-making along 4 axes. When to do open versus robotic surgery. When do I do a traditional transperitoneal versus a retroperitoneal approach? What tumors are appropriate for tumor nucleation versus maybe the more traditional wide excision? And when do we need to clamp the renal hilum? And when is it more advantageous not to clamp? So I'll go through each one of those, and then we'll come back to the case. So open versus robotic, I think that the biggest driver here is really surgeon experience and comfort. And that depends a lot on your training. If you have trained to do complex partial nephrectomies via an open approach, that's a fantastic approach to treat many renal tumors. I will say though, because of the increased utilization of robotics over the past decade, that more and more trainees have more exposure to robotic, and in many programs, almost exclusively robotic. So because of that, I think the current generation of trainees, and certainly in the future, will be doing many of these robotically. Another consideration is the need for cold ischemia. And for a long time, there was dogma in kidney surgery that every minute of warm ischemia counts, and 15 minutes is quantitatively better than 16-minute ischemia. And I think a lot of that has really been disproven, and a lot of that by the seminal work from Steve Campbell and the thought leaders at the Cleveland Clinic, who've showed that ischemia, as long as it is a reasonable amount of time, in the half-hour ballpark, does not make a difference, and it's really more of the parenchyma of the kidney that's preserved. However, there still may be cases where cold ischemia could be preferable for a patient with a solitary kidney and a complex renal mass. You just heard the very nice talk from Dr. Linehan about the genetics of kidney cancer and of certain hereditary syndromes. And we feel very strongly that patients with HLRCC or patients with SDH deficient tumors can benefit from open surgery. These are aggressive tumors, even when they're small. They don't have normal tumor pseudocapsules, and they can infiltrate widely into the normal renal parenchyma. And we feel that you can do a more complete resection without the risk of maybe tumor rupture via an open approach. And there may be some considerations for the patient's surgical history. If they've had prior renal surgeries, it may sometimes be advantageous to approach those via an open approach. We feel strongly that there are many cases that robotics can still be preferable, but again, that goes back to the comfort of the surgeon. And we're at the AUA, so let's see what the AUA guidelines have to say. Guideline statement 22 at the bottom here. In patients undergoing surgical excision of a renal mass, a minimally invasive approach should be considered when it would not compromise oncologic, functional, or perioperative outcomes. I think it's a very reasonable way to think about it. Now, how do we get to the kidney? I think that for most of us who do robotic kidney surgery, the transperitoneal approach is probably the more comfortable, probably the more default. Certainly in my training, 90% plus were transperitoneal. It's more familiar anatomy. You can see the great vessels, the renal hilum, reflect the colon, and that gives you more working space. But there are certainly cases where having a retroperitoneal approach in your toolbox can be advantageous. It's great for posterior tumors. For a posterior tumor, it can be challenging to see the base unless you really flip the kidney transperitoneally. It can be a challenge for your surgical assistant to give adequate suction at the base of the tumor, and this is really ameliorated with an RP approach. There are caveats, though. It comes with less familiar anatomy, less working space, but again, the quicker access to posterior tumors and to the base, I think it makes it advantageous for those select cases. Now, this is a very common question and topic of discussion among kidney cancer surgeons. How much of a margin is enough? When should you do a standard wide excision partial nephrectomy versus tumor enucleation? And so the way I think about it is when we really need to preserve renal parenchyma, when that's paramount, then tumor enucleation can be beneficial. So you can see at the bottom, patients with certain types of familial RCC syndrome. So not SDH, not HLRCC. We heard those are bad actors. But for the other ones, for von Hippel-Lindau, for Birt-Hogg-Dubé, for hereditary papillary renal cancer, these are good candidates for tumor enucleation. They have robust pseudocapsules, and they're at risk for multiple tumors throughout life, so preserving parenchyma is paramount. For patients with certain types of multifocal disease that don't have a genetic basis, and for patients with severe CKD, all those patients can benefit from tumor enucleation. For the most common scenario, though, the patient with a 3-centimeter lower pole renal mass who's in their 60s and does not have a hereditary predisposition and has normal kidney function, enucleation is not necessary. And in fact, you might be better off taking a margin of normal renal parenchyma in that case to ensure that you have good oncologic results. But the benefits of tumor enucleation, besides preserving the parenchyma, for certain complex masses, it's helpful to be able to see the edge of the tumor as you're going around, and particularly to avoid entry into the collecting system, or for hilar tumors to avoid inadvertent entry into the renal artery or vein. And if you're doing an off-clamp approach, which we'll talk about in the next slide, even if you enucleate, you're going to have much less blood loss than if you take even a small amount of renal parenchyma. So to me, tumor enucleation and off-clamp sort of go together in my mind. And so off-clamp. When do we do this? Well, a common scenario that we see at the NCI are a patient that presents with multiple tumors, and we can't clamp the kidney long enough to safely get 5 tumors out without detriment to the renal remnant. So there are certain cases where we are obligated to at least tackle some of those off-clamp. For the patient with a solitary kidney, I think less ischemia is better there, particularly if you think there's going to be prolonged ischemia. There are many times where you can start off-clamp and only clamp for the deepest portion of the tumor to really make sure that your interval is not too long. For patients with previous kidney surgery, where the renal hilum is scarred, sometimes you can't adequately clamp the renal vessels, and there are times that could be a consideration. And particularly germane for patients with hereditary syndromes and planning for future surgeries. If we're dealing with a very exophytic tumor where it's not going to bleed this time, maybe we don't fully dissect the hilum because we know that in 5 to 10 years, we will have recurrent tumors, and they may be in a location that's not amenable to an off-clamp approach. So many people in their training have only done wide excision partial nephrectomies. So what does it look like to do a tumor enucleation? Let's see if this video will, yeah. So what we're doing in tumor enucleation, the hilum is not clamped here. We're really brushing every millimeter of parenchyma off until we see the very shiny surface of the renal tumor pseudocapsule. There's some bleeding that can be addressed with manual compression with a sucker, but you can usually avoid arterial bleeding, and you can see that if you're in the perfect enucleation plane where you don't have the strings, the fibers of renal parenchyma, that hemostasis is not a challenge. And so the next step here would be to do your renorrhaphy. So let's come back to this case. So we decided to tackle the left side first, and you can see this is a large tumor, and it does abut the renal sinus, but I thought that there was a higher chance of saving the kidney here than for the other side. So thinking about decision making, we decided to tackle this robotically because it's large. Even though it's posterior, because of the large size, I did not think we would have adequate room via an RP approach. So we did transperitoneal. I did a wide excision because it's larger, and I was worried about oncologic efficacy. And because I'm doing a wide excision, because it's deep, I did elect to clamp the hilum. So what that looks like, we just saw a tumor enucleation. For wide excision, you really are starting not on the pseudocapsule, but just a little bit off. And the difference here, you can see the sort of the fibers of renal parenchyma rather than that smooth capsule. And that's how you know that you're in the wide excision plane rather than the tumor enucleation plane. We're clamped, so blood loss is not really a consideration here. We have a nice visible margin throughout. And because this was larger, the ischemia time was about 29 minutes. We lost 350 cc's, and the pathology was consistent with an 8.5 centimeter chromophobe RCC, negative margins, and he had good kidney function at discharge. Now, interesting, the other side was biopsied as clear cell. This was a chromophobe. There's only about an 80% concordance rate when patients have sporadic patients present with multiple tumors. So we do see multiple histologies. And we have seen patients who have benign histologies, maybe they have an oncocytoma and a clear cell on the other side. So something to always keep in mind, you can't assume that what is on one side is necessarily what is on the other. So 6 weeks later, it was time to tackle the right side. And so this is a completely endophytic tumor. You can see there's no bulge at the renal capsule. It's completely endophytic, covered by about almost a centimeter of normal renal parenchyma. We decided to tackle this robotically, again, transperitoneal, wide excision, and to clamp. When we went in, though, we saw the tumor on the ultrasound. You can see in the middle of the screen, and it is intimate with the renal sinus and the hilar vessels, as we circle there. Intimate with the vasculature. So you can do a partial nephrectomy here, but my concern with a clear cell versus the chromophobe on the other side, a clear cell here in this location can often be infiltrative into this renal sinus vat. So we made the decision actually to convert this to a radical nephrectomy, and I'm glad we did. This ended up being a Furman grade 3 clear cell with extension into the renal sinus vat, so a pathologic T3A. Happy to report the patient's doing well. Did not need renal replacement. His final GFR was around 40, so he does have CKD, but he is not at risk for dialysis, and he's been tumor-free for the last 18 months. So case number 2. This is a woman in her early 40s who contracted COVID-19, had some symptoms, so had chest imaging, and on that chest imaging was found to have a renal mass or renal masses. She was otherwise healthy with no comorbidities. Interestingly, she did have a family history of spontaneous pneumothorax, but no history of GU malignancies. So this was the cross-sectional imaging that the patient had. You can see multiple large renal masses in both kidneys. Large, some are deep, some are abutting the sinus vat. So when we see a patient like this, how do you proceed with workup? And there are a lot of options here. We could think about biopsy. This is a patient who is young, so maybe there are considerations for hereditary kidney cancer causes as well. And so this is work that was done by Brian Shook when he was at the NCI looking at defining early onset kidney cancer. And the crux of this paper was comparing the SEER database of patients with sporadic kidney cancer to those with a diagnosis of hereditary kidney cancer. And it was found that the cutoff that best predicted hereditary and had the sort of most false, had the least false positives for sporadic was at an age of 46 or less. And work presented this meeting by one of our fellows, Alexei Ron-Paper-Dor. He found that for patients with enrichment features for hereditary kidney cancers, so for bilateral multifocal, for early onset, or for familial renal cell cancer, that the more of those features you have, the more likely you are to have a positive germline test. And so for this patient, we did do genetic testing. This patient had Burt-Hogg-Dubé, a alteration in the folliculin gene. We decided to use a sestamibi scan here to further characterize this. Sestamibi is a mitochondrial imaging agent, and for tumors that are mitochondrial rich, including oncocytoma or hybrid tumors seen in BHD, those will light up. These all lit up consistent with hybrid tumors. So because this patient had hybrid tumors, which are thought to be of low biologic potential in terms of metastasis and recurrence, we were able to offer this patient a robotic transperitoneal enucleation with a mixture of on-clamp and off-clamp techniques. So this patient went staged bilateral partial nephrectomies. 6 tumors were removed on the left side. The largest was 8 centimeters. All were hybrid tumors, and 5 tumors were removed on the right. The largest were 8. All were hybrid, and the patient had a postoperative GFR of 81. And what made this really possible was using enucleation rather than wide excision. You can see the postoperative scans here. So this patient is now NED about 12 months after surgery now. So in terms of partial nephrectomy, the decision to perform, really you're weighing the oncologic risk versus competing risks of surgery for any individual patient. It requires the input of patient, tumor, and surgeon factors. What are you comfortable with? What is the patient comfortable with in terms of the risk of surgery versus recurrence versus surgical complications? But being facile, really, with each of these 4 axes gives you a lot of options. 2 to the 4 or 16 different surgical options for partial nephrectomy. And so I have just a couple minutes left, but I do want to briefly touch on how we think about cytoreductive nephrectomy. Now, this is a topic that's garnered a lot of attention for many years, but especially in the last 3 years with the publication of the Carmina and Surtime studies. So just very briefly, this is a 47-year-old patient who presented with 10 pounds of weight loss, night sweats, and anemia. Imaging showed a left renal mass and multiple sub-centimeter pulmonary nodules. She had hemoglobin of 8.3. All other labs were negative. So, you plug this into the calculator, to the MSKCC or the IMDC calculator, and this was an intermediate, IMDC intermediate patient. And so we can see the imaging of the renal mass on the video is not loading here. Large renal mass, and you can see on the chest imaging we have several pulmonary nodules, round, well-circumscribed pulmonary nodules. The largest is about 9 millimeters, a total of 3 pulmonary nodules. So what are the treatment options for a patient like this? Is this a patient a good candidate for upfront cytoreductive nephrectomy? Would a biopsy be helpful here? What about upfront systemic therapy? And I'm sure that there could be reasonable disagreement on the best way to proceed for this patient. Maybe show of hands in the audience. Who here would think about upfront cytoreductive nephrectomy for this patient? Okay. What about upfront systemic therapy? Okay. Yeah, about 50-50. So in this case, the patient elected upfront cytoreductive nephrectomy. And the reason we felt good about this option was this patient had large disease burden within the kidney, had pretty limited disease burden outside the kidney, really such that we would not necessarily, this patient would not necessarily need to start systemic therapy right away. And the EAU guidelines suggest that if a patient has minimal disease outside the kidney such that they would not require immediate therapy, maybe that could be an appropriate patient for cytoreductive nephrectomy. What was interesting is her anemia resolved. This was a paraneoplastic anemia. It resolved completely. Her night sweats, fatigue, B symptoms all resolved. She did start Ipi-Nivo 2 months after surgery, and she's alive with stable disease. She still has these pulmonary nodules that are really the same size as they were then. They were eventually biopsied. They were confirmed metastatic, but she's doing well. This patient also had a lymph node dissection because we saw what we thought was an enlarged node at the time of surgery. It ended up being benign, but it's a common question. What do we do? When do we do lymph node dissections? And the answer that the literature currently supports, and this really comes from Mayo, which was a center that did a lot of lymph node dissections, is that it makes sense for a patient with clinically enlarged nodes. For most patients without clinically enlarged nodes, there's probably not a role for upfront lymphadenectomy. Now, there are some subtleties. There are some diseases that we manage, like HLRCC, where maybe lymph node dissection upfront does make sense. But for the average patient who presents with a large renal mass and clinically node-negative disease, those patients probably do not need a lymph node dissection. In the interest of time, I will just show, to compare that first case. This was a patient that presented around the same time with a large renal mass and what we thought was limited disease on the outside scan. When we staged them with an MRI, you can see too numerous to count lesions within the liver. So this patient presented with hepatic, osseous, and soft tissue disease, as well as enlarged lymph nodes. Who would do a cytoreductive nephrectomy for this patient? Yeah, this patient, multiple sites of disease, a lot of extra renal disease burden. So this patient actually went on to have systemic therapy. She was IMDC poor risks with three risk factors. And she's done well now for about 18 months on systemic therapy, although she has progressed through a couple of lines. So in the interest of time, there's some data that's in the handout that's available through the Swap Card app. I encourage you to look through the history of sort of why we've done cytoreductive nephrectomy in the past, maybe some of the challenges that the Carmina data have added to that and to the Surtime studies as well. But I will say that in the future, there will probably be more of a role for patients to receive upfront systemic therapy with consolidative nephrectomy overall. I think surgery will still play a big role in this space, but I think that will change as we get better therapies. So thank you very much for your attention, and happy to answer questions at the end, and we'll move along.
Thanks, Dr. Ball. I'm very happy to introduce Dr. David McDermott, who's from the Beth Israel Deaconess Harvard Cancer Center. We're thrilled to have him international expert in this. David, thank you for coming. I'd love to hear the exciting new work you've got.
Okay, well, I always appreciate getting invited to AUA, any surgical meeting, actually. I'm going back to, I'll tell this story as they work to get my slides up, I guess. Going back to medical school, I'm sort of a wannabe surgeon, couldn't quite hack it, but I always looked up to a lot of my surgical colleagues in my class. They were always sort of the cool kids in class, and a lot of my chief residents were very impressive people. The other reason I like talking to surgeons is, you guys say kind of cool things like the chance to cut is the chance to cure. That was one of the big cliches back in medical school. Which always seemed interesting to me. And it's that point about surgical endpoints that you understand that actually many of my medical oncology colleagues don't focus on. And immunotherapy, at least in some cases, I focus on developing solid tumor immunotherapy, can deliver. And that's what we'll talk about today. We'll talk a little bit about immune therapy for kidney cancer and its role, I hope, and then how it fits into your surgical management of your patients. Where are we with this? Yes, sir. You want me over there?
Okay, we're just going to get his slides up. Dr. McDermott's going to go over and look. While he's doing that, I want to ask a couple of questions of Dr. Ball. Dr. Ball, I wasn't really clear on the business about when to do lymphadenectomies or not. Could you give me that again? Just sort of, I'm seeing a patient, when do I do lymphadenectomy?
Absolutely.
Need something straightforward.
Yes. So it really boils down to, are there enlarged nodes on imaging? So a patient who has enlarged nodes, who is otherwise is going to surgery, I think it makes sense for that patient to have a lymphadenectomy, and the data would support that not all patients with enlarged nodes will have metastatic disease in those nodes, but many will. Conversely, for the patient with clinically node negative, maybe they're high risk, it's a large tumor, or there's a renal vein thrombus, the data doesn't support to do a routine lymphadenectomy in those patients. Granted, sometimes there are game time decisions, you see something intraop that you don't see on imaging, but to do that routinely would not be the answer that's supported by the literature in 2022.
All right, great. So, okay, so that helps a lot. So let me ask another question. I'm a little confused about this. So we talked about genetics and genes and all these different things about kidney cancer. That's great. It helps us think and all this, that, and the other. However, I'm out there. I'm a urologic surgeon. Patient comes to me with a, I don't know, let's say a 3-centimeter renal mass. When do I take it out? When do I not? When do I nucleate? When do I go wide? Also, I don't know. I hear about these papillary things. Maybe they can be worse. Okay, here's some guy comes. He's got no family history. Got nothing that I know. He doesn't know his family. I don't know anything. What do we do? When do you biopsy or not? Or kind of go on your radiologist on the imaging? I mean, we've all seen some things that didn't turn out so well. Some did a partial, had a positive margin. How do we think about this?
The nice thing about practicing today is we have more tools than we've ever had to attempt to risk stratify patients. I think that biopsy is increasingly utilized, and some people argue that you don't need to do biopsy because it doesn't change management, and it doesn't always, but there are many times it does. For a mass that maybe is located in a difficult location where radical nephrectomy is on the table, I think it makes a lot of sense to do biopsy. Maybe the patient has an oncocytoma and they don't need a radical nephrectomy for a 3-centimeter oncocytoma. So I think that it's imperative to discuss the option of biopsy with every patient and counsel them accordingly about the risks. We have features we can glean from imaging, from both conventional imaging with contrast-enhanced MRI or CT. We also have newer nuclear imaging techniques like sestamibi scans that can differentiate oncocytomas and oncocytic tumors from clear cells and others. So for the patient where we don't have some of these more novel tools, they have a 3-centimeter tumor that looks amenable to partial nephrectomy, does that patient need a nucleation? I probably would not, because I don't know what we're dealing with. Maybe it's an aggressive clear cell. Probably not. Most of the time it won't be, but sometimes it will be, and you will regret that if you take a minimum margin.
Okay. Let me ask Dr. Srinivasan a question. Dr. Srinivasan, you heard Dr. Ball up here talking. You're, of course, a medical oncologist, and we all work together. But let me ask you this. Dr. Ball was talking about cytoreductive nephrectomies for people with advanced disease. Okay, now here our audience. Here we are. I'm a urologist. I'm in the real world. I'm seeing a patient comes to me with advanced disease. I biopsy him, and it's clear cell. But I biopsy him, it's papillary. There's some funny papillaries out there and this, that, and the other. How does that make a difference in the where? Of course, it's a joint thinking between the urologic surgeon and the medical oncologist. I realize that. But where do you come in on this? I mean, as far, I know you give a lot of thought to this, as far as active surveillance, cytoreductive nephrectomies, and also, are there any people with metastatic disease, maybe kidney in place even, that you would say, let's don't do either. Let's just watch it. What do you think? I know this is a little more complicated than I thought it was. What's your thinking on that? You know what? Maybe we'll hold that. Are you ready, Dr. McDermott?
So maybe we should let him talk.
Here we go. Dr. McDermott's ready to go. So I'll come back to questions. I want to hear your thoughts about that and Dr. McDermott. Thanks a lot.
All right.
Thank you.
Sorry about that. So back to what surgical endpoints I mentioned. They're more interesting, I think, than medical endpoints. Let's talk about how those play a role with immune therapy and solid tumors. Here are my disclosures. I mentioned also that I look up to several surgeons. This is one of them. This is a picture in the top left of Steve Rosenberg, one of Dr. Lenhan's colleagues at the National Cancer Institute Surgery Branch. He and others at the group essentially developed the field of solid tumor immunotherapy. Initially with cytokine therapy with high-dose IL-2. You're looking actually at an X-ray here of a patient with metastatic melanoma. In those days, this is pre-CT scan. You can see a dramatic response with high-dose IL-2 in those patients. And this is a response duration curve that my colleague, Dr. Mike Atkins, is also shown on this picture, developed for patients receiving high-dose IL-2 and kidney cancer. And you see patients with responses, those responses going out 10 years, well after therapy is stopped. Those patients are living in remission of their disease. So essentially, high-dose IL-2 proved an important principle that remission or cure was possible with solid tumor immunotherapy. But unfortunately, because these responses were relatively uncommon and the toxicity was significant, and you were giving and medical oncologists would need to give this therapy, who are less brave than surgeons at the NCI, this approach did not really reach that many patients with either melanoma or kidney cancer. Not until some discoveries that actually led to a Nobel Prize in medicine a few years back that went to Dr. Hanjo, who's shown on this slide, not until we started to understand how tumors can actually shut off an immune response and maybe how we could block the interaction between tumors shutting it off an immune response and getting a tumor to, an immune system to kill a tumor, not until these discoveries of Dr. Gordon Freeman and others did we actually make major progress in the field of solid tumor immunotherapy. So-called, Dr. Freeman helped us understand how PD-L1 expression on tumors could be blocked and could lead to tumor regressions. Did we start really making major progress in this disease? In kidney cancer, sort of the paper that led to the approval of PD-1 blockade with nivolumab was this one here in New England Journal of Medicine. Dr. Motzer led this work. In patients who had failed prior VEGF therapy, nivolumab was superior to mTOR blockade, leading to its approval about 7 years ago. But for most patients we see, a little background science here, most of the patients we see in the clinic with tumors actually present in what we call immune escape. As you can see on this slide, sort of the 3 E's of immune editing. When you give them PD-1 blockade, you can reset that balance between the immune system and the tumor, actually gaining more control over the tumor, leading to sort of an equilibrium. But for most patients, in most cases, not just in kidney cancer, but for example in bladder cancer, we're not seeing the complete responses that we saw with high-dose IL-2. We're seeing sort of an equilibrium that's usually temporary for most patients. You know, we gain control, but eventually the tumor figures out how to escape. We're not eliminating the tumor. So how might we do better as far as eliminating tumor? Well, the obvious next step for many in the field was let's think about combinations. Let's try to enhance the anti-tumor immune response by adding other agents that have been shown preclinically to enhance the immune response to the tumor. There was certainly some evidence that VEGF blockade did that in mouse models, either by improving the infiltration of T cells into the tumor or enhancing, for example, the impact of dendritic cells. Also, CTLA-4 blockade and its role in priming and activation of the immune system was thought to play a role. And so logical next steps, once we had PD-1 as our base, was let's add to it in different ways, and that's what folks did. And essentially, some of the initial trials were essentially fusing the old first line, which was VEGF blockade, with the new second line, which was PD-1 blockade. And quite a few trials were launched with these combinations. The first one to show significant impact was this one here. Pembrolizumab and axitinib was shown to be superior to sunitinib in the frontline treatment of patients with metastatic kidney cancer. Essentially changing the paradigm for how we treat many of these patients. Subsequently, that was built upon by the combination of PD-1 and CTLA-4. Once again, Dr. Motzer leading this, also showing superiority to sunitinib. So leading to also PD-1 and CTLA-4 becoming a standard approach for untreated kidney cancer patients with metastatic disease. We've essentially seen a series of positive pivotal trials in the frontline setting, most of which have the same design, most of which are VEGF plus PD-1. Nivolumab and CTLA-4 being the only outlier from a mechanistic point of view. And we spend a lot of time at medical meetings trying to decide which regimen of these options should be favored. If you look at sort of the clinical take-homes of these different approaches when you're trying to decide what to offer your patients, there are pluses and minuses with each approach. As shown on this slide, with PD-1 and VEGF, we see improved survival, which is great, but we also see higher response rates and a small number of patients who progression of disease is their best response, and longer times of progression-free survival. With CTLA-4, we see overall survival improvements, and we see what we'll focus a little bit about. We also see durable responses and the potential to stop treatment and having the benefit be maintained. And, we could spend some time debating this question. Honestly, I don't know that you care all that much, and to me, it's kind of a waste of time because it would require us to do cross-trial comparisons, which we all know are flawed. These trials have unequal follow-up durations, so it's hard to make comparisons. And also, when we're talking in front of medical oncologists, there's no agreement on what I would call the hierarchy of endpoints. Like, what endpoints for these trials are most important for you or most important for your patients? And we'll talk a little bit about that, getting back to my surgical days. Early endpoints I would describe as endpoints that happen, in the first 2 years of treatment. These are favored by industry for obvious reasons to try to get answers to their questions early. And they're also used by the FDA for many of our approvals. They're certainly important for symptomatic patients. So if you have a patient with metastatic kidney cancer who's symptomatic, you want a response. So an agent like VEGF and PD-1 that will offer you a chance at a major response early could be preferred. But late endpoints are often important for patients. And I would describe late endpoints as those that develop after 2 years of treatment. These are also favored by many of you in surgery and by our colleagues in stem cell transplant, where you see a patient with a tumor, you take the tumor out, and you walk away. And you only congratulate yourself if the tumor is all gone. No one pats themselves on the back for a partial resection of a tumor. And because it allows the patient to live in remission, off treatment, and not needing a referral to medical oncology. And the endpoints that measure a durable response are things like duration of response, landmark progression-free survival, and long-term overall survival. But I'd like to add a third class of endpoints into this discussion, which are the so-called durable endpoints. And like surgery, they develop after treatment stops. And many of my medical oncology colleagues are actually very hesitant to stop treatment, even when it's working. But it's also often favored by patients, because as soon as you come off treatment, you come off the side effects of treatment. And we're developing a sort of a comprehensive measurement of the benefits of immune therapy we call treatment-free survival, which I'll talk about in a second, which tries to give us a sense of both the pluses and the minuses of immune therapy for a population. So when we're comparing these studies, what do we see with more follow-up? Well, interestingly, when you look at overall survival, the overall survival numbers for PD-1 VEGF were tremendous initially, but with more follow-up, the hazard ratio for overall survival is going up in many of these studies. And also, if you look at the favorable risk group, which is the group where VEGF levels are the highest in general, hazard ratios are going up even more dramatically in that group, which is not what you would expect, I think, if blocking VEGF was leading to an improved immune response to the tumor. In contrast, when you look at PD-1, CTLA-4 over time, while the hazard ratio for overall survival was not as impressive early on, when you look at follow-up, those hazard ratios are staying stable, and they're actually improving for favorable risk patients. Moving to progression-free survival, comparing the two approaches, you see a plateau in the progression-free survival curve for PD-1 and CTLA-4. About a third of patients are alive, progression-free on that trial, at 5 years. Many of those patients are in remission of their disease, whereas with PD-1 VEGF, those curves are sagging. Now, they may develop a plateau over time, but they haven't yet. And this may be true for a number of these different combinations. So when deciding which option of PD-1-based combination therapy is best for your patients, it depends on what you're trying to achieve. An early improvement, then PD-1 VEGF makes sense. A durable improvement, so far the data with PD-1 CTLA-4 are encouraging, but we need more follow-up. And then we'll talk a little bit at the end of this talk about the durable outcomes that we see post-treatment, so-called treatment-free survival. But comparing these regimens, we could spend a lot of time doing that, but I think the actual more important question is if we can create remissions of metastatic kidney cancer, if you actually believe that's possible, if your answer to that question is yes, then I think as a field, what we need to do is work to make that more common as our primary goal, not the only goal, but as our primary goal. So, my colleagues, as Dr. Lenahan mentioned at DFHEC, are focused a lot on that. This is the group who leads that effort up in Boston, and I'm going to talk a lot about their work. One of the things we focus on to try to make cures more common in kidney cancer is to continue to rationally apply this approach through developing biomarkers that are predictive of response, because ultimately immune therapy should not be provided broadly to all of our patients. There are just some patients, particularly those who do not have a pre-existing immune response to their tumor, that are never going to benefit from immune therapy. So how do we identify those patients? Well, in kidney cancer, it is not easy, in part because of what we see in many of our patients, this so-called intratumoral heterogeneity that the group from England, the TracerRx group, has told us about for over a decade. This makes biomarker development almost impossible in kidney cancer, but doesn't mean we shouldn't pursue it. And there are many different groups that have pursued many different tissue-based biomarkers for outcome. The best one, at least at the moment right now, and this goes back to your original questions, is probably sarcomatoid histology, where if you look at patients with some aspect of sarcomatoid histology in their tumor and their long-term outcomes, their plateaus on their survival curves are impressive, even better than all comers. So of all of these, probably progression-free survival is, at least at the moment, the best predictor of outcome. If you see a patient like that, they should almost certainly get PD-1-based blockade therapy initially. We're taking this even further. This is a recent publication in Cancer Cell trying to subset individual kidney tumors based on molecular signatures. These are RNA signatures in the tumor, and we're making some progress, but it's not yet ready for a time as sort of a companion diagnostic. But with this work, it looks like tumors, not surprisingly, who have an RNA signature that's full of T effector cells signatures, they're more likely to respond to immune therapy. Those tumors with VEGF signatures, more likely to respond to VEGF alone. And then there's some patients who are not going to benefit from either approach, and we shouldn't be offering them immune therapy, in my opinion. We were asked to provide a case. This is one of my patients, a 65-year-old man with past medical history of obesity and diabetes, had a large right renal mass, otherwise normal blood tests. He underwent a nephrectomy for this tumor that you see here in the right renal mass. And then the question was, the patient was referred to us for consultation. The question is, what's the most appropriate next step for this patient? And you see your choices, and there is potentially more than one right choice to this, but the answer number 4 is going to become an increasingly correct answer, potentially, for these patients, based on this trial here that was published in the middle of last year in the New England Journal of Medicine. This looks at bringing immune therapy earlier into the paradigm, which is where we're starting to see some encouraging results in multiple tumor types. This is bringing it mainly into stage 3 patients, comparing it to placebo. Dr. Choueiri led this study, and this is the so-called Keynote 564 study, where patients were randomized to receive pembrolizumab for up to a year. And here are the results. Disease-free survival improved for patients getting PD-1 blockade with a hazard ratio of 0.68. This was an encouraging result and led to the drug's approval. And if you look at that improvement, though, based on a different pre-treatment characteristics, a lot of the benefit is being driven by, at least at the moment, by patients who presented with metastatic disease and had their disease resected, and then they went on the study. So time will tell if this is an approach that we should be broadly applying to all of our patients, or just to patients with more aggressive cancers or more aggressive presentations. And one of the interesting things, at least initially, is there seems to be at least a small survival signal Obviously, there are not many events driving this, but this will be important in determining who we use this for. Does this survival signal last with time? It may or may not. What are we learning from other tumor types as it relates to adjuvant therapy? We'll also treat melanoma, and we steal a lot of great ideas from them because it's been a therapeutic proving ground for a lot of solid tumor immunotherapy. Well, if you look at immunotherapy application in melanoma, it's approved right now for all stage 3 patients in the US based on this data and other data, but essentially it's not being used for 3A patients at most academic centers, in large part because there's probably not a great balance between the toxicity that you see with the agent and the true risk of patients recurring. So this is sort of a post-approval modification that many of us have used just to follow 3A patients, which are frankly the most common patients we see in academic centers. And this could happen also in kidney cancer, meaning a blanket approval early that gets modified, hopefully by tissue-based biomarkers in the future. And just sort of getting to the end of my talk, I want to talk a little bit about novel endpoints that might appeal to surgical colleagues. This is the so-called treatment-free survival comprehensive method that I mentioned earlier, where we're looking at survival states over the course of all of the patients on a study and how'd they do. In purple, when they were on protocol therapy, in blue, when they were on the study but off therapy, in gray, they're on the subsequent treatment, and obviously black is death. We actually compared outcomes, comparing treatment-free survival and survival states with PD-1 versus VEGF. And not only was overall survival, as I mentioned, greater with immune therapy than VEGF blockade, but treatment-free survival was twice as long. So you are more likely to be alive and twice as likely to be alive off treatment. Now, that's at risk, so obviously immune therapy brings greater potential durable risk, and we're also measuring durable toxicity as part of this method. But it's a trade-off that's at least worth a discussion with patients, in our opinion. What else are we doing? What are we learning from actual patient tumors besides prediction criteria that might improve our immune response to the tumor? We're actually trying to interrogate the tumor microenvironment to develop new therapies. I don't have too much time to talk about this, but things like neoantigen-based vaccines, novel immune checkpoints, CAR T cells are being developed in kidney cancer, and TIL therapy is also being developed in kidney cancer. Some of my colleagues at Harvard are trying to use information from the tumor to say, what are the best targets we should be going after. This is work by David Braun, who's now at Yale, and Kathy Wu, who's up at Dana-Farber, using single-cell sequencing to identify exhaustion targets. One of the targets they found is present in a lot of the immune cells in kidney tumors is LAG3, which is another immune checkpoint pathway. Recently, in melanoma, once again stealing from melanoma, PD-1 plus LAG3 has been shown to be superior than PD-1 alone and has gotten FDA approval in combination of melanoma. We're trying to use the data that Kathy and David have generated to hopefully convince companies to develop this combination in kidney cancer, trying to do it in a rational way. There's a lot going on back here. We're trying to develop even novel checkpoints that haven't been identified by industry. Once again, going back to Gordon Freeman here and my colleagues at Beth Israel, Kathleen Mahoney, and Rupal Bhatt, identifying a new pathway they think could be important, the so-called HHLA2, KIR3, DL3 pathway. This is a pathway that's normally stimulatory to T cells, but they've actually found a receptor that's actually inhibitory to T cells that can be drugged. And this pathway is expressed on many different tumors. So they're hoping to drug this pathway in similar ways that we drug CTLA-4 in hopes of enhancing an immune response to a tumor. So once again, taking human samples and trying to identify new targets for immune therapy. I mentioned CAR T is also in early development. TIL therapy, where this goes back to the early days at the NCI, and I'll finish up here, where you actually take the patient's tumor, you take it out surgically, you prepare the patient's immune system by suppressing it with chemotherapy, and you give back these energized tumor-infiltrating lymphocytes, in the context of high-dose IL-2, so it's sort of the kitchen sink of immune therapy. This has shown some impressive results in melanoma and lung cancer and cervical cancer, and we're hoping to bring it into kidney cancer, at least in the clinical trial space. It's possible this will get FDA approved for melanoma sometime in the next year. There are several companies working on this. So I hope I've been able to convince you that my colleagues are doing some good work, bringing immune therapy closer to the front, earlier in the disease with adjuvant PD-1 blockade. Importantly, focusing on endpoints that are surgical in many ways, but focus on patients and their desire to live in remission of their disease, like treatment-free survival. And also, folks are doing some interesting scientific work. Marcin mentioned this earlier, and Ram will talk about this in his next talk. My colleague Bill Kalin won the Nobel Prize for some of his work in targeted therapy for kidney cancer, looking at targeting the HIF2 alpha transcription factor, and you'll hear more about that in the next talk, assuming it's happening. And hopefully we'll get to the point by throwing all of this together that the standard therapy when we get together maybe 10 years from now is we're going to rationally apply immune therapy based on the profiling of the tumor microenvironment, and increasingly second-line therapy will not be necessary because we'll have more patients living in remission, and not on therapy. So these are my colleagues who contributed to all this work. Obviously, my NCI folks, colleagues, who I cherish, who worked hard on the VHL HIF story. That will be in the story in the next talk, but we're excited to be here, and I'm glad to take any questions.
Thank you, Dr. McDermott. I mean, it's just amazing to me to think about where we are with the science, how much it's going to impact how we as urologic surgeons manage patients with you. And, it's funny you mentioned TIL therapy. I remember the first, you're not going to believe this, but the first TIL therapy given to a human was grown in my laboratory by Arie Beldegrun, if you can believe that, way back when he was a fellow. And we treated he treated a patient one evening with that. And the patient actually had a very nice response. And anyway, while we're getting Dr. Srinivasan's slides, sorry about the IT issues, but we're getting it all squared away. Let me ask you a question, though. I'm kind of interested to know a couple things. One, what would you, and I love your emphasis on cures, that's what we need to be focusing on. Now, what would you get? I know you do a lot of thinking about this and presented some incredibly exciting data. We've made so much progress. Let me ask you the following. What would you think, with all your years of experience, as far as what might be the final solution? What might lead to cures? Okay, why don't you go ahead and answer that, and then Dr. Srinivasan.
Well, I think at the moment...
I mean, combination of drugs, targeted plus immuno, what do you think?
Well, I think we're already curing patients with metastatic disease. We've been doing it for 30 years with immune therapies like high-dose IL-2. We do it with combination PD-1 blockade now, but we have to be willing to see that outcome. We have to be willing to stop the treatment in our best responding patients, which a lot of colleagues in industry is certainly they're not willing to explore stopping drugs. So I think that those cures are out, certainly those remissions are out there. But it's not all going to be an immune therapy story. There are patients whose tumors are going to be completely resistant to immune therapy, and then we need to be developing novel targets for those patients. We're going to hear some of that in this talk now. I don't think targeted therapy is dead for kidney cancer, but we need to be more like our lung cancer colleagues, where we identify the pathway that's driving the tumor and we provide the drug based on that, instead of what we're doing now, which is sort of a broad application of all the drugs that we have. I think that's going to slow us down. And that's where unfortunately, that's where the field is going as the next step. I didn't get into this, but we're starting to go into triplets for just all comers. And I honestly think that's going to slow us down, personally.
All right, we're happy to have Dr. Ram Srinivasan, who's going to talk about novel treatments for kidney cancer genes to therapy. Dr. Srinivasan.
Thank you, Dr. Linehan, and it's a pleasure to be here this morning to be wrapping up this session. And I think Dr. McDermott's comments, provide a great segue into the topics I'm going to be covering today. I'm a medical oncologist by trade, but I've worked with urologists and urologic oncologists for the last 17 to 20 years. And I can tell you confidently that over this period, I've started thinking a little bit more like urologists, and I dare say that my urology colleagues have started thinking a little bit more like me. I think it's good for the field that multiple lines of thought come together, because I think is the way to true development. One of the common jokes within our group is that I recommend more surgical procedures than the surgeons do. It's easy for me to do because I'm not actually doing the procedures, they are. But hopefully I'll show you over the next 20 minutes or so how working together as a group, urologists, medical oncologists, basic scientists, has really helped us advance some really novel ideas into the clinic. And we'll see at the end of the talk what you think. Dr. Linehan talked to you about how diverse kidney cancer is, and just because we call these various entities kidney cancer doesn't mean they're all identical. A variety of different genes driving a variety of different histologic subtypes of cancer, all of which seem to occur in the kidney. With all the knowledge we have about how these different forms of kidney cancer arise and occur, it'd be a shame if we didn't exploit that knowledge really to design targeted therapeutic strategies that were individualized for these distinct subtypes. And that's what we have tried to do in our group over the last 15 years or so. I'm going to be spending most of my time here today talking about specific forms of clear cell kidney cancer and papillary kidney cancer, the two most common forms of RCC that we encounter in clinical practice. As you know, the basis for targeted therapy approaches in patients with clear cell kidney cancer has really been understanding the VHL pathway. So most of the early treatment options that we've had for treating patients with advanced clear cell kidney cancer came from an understanding of how loss of the VHL gene leads to kidney cancer formation. And while we were initially unable to target some of the key downstream events that followed VHL loss, we were able to successfully target several downstream consequences of these events, and successfully for quite some time. With the advent of immune checkpoint inhibitors, as Dr. McDermott mentioned a few minutes ago, the treatment in the last 4 to 5 years of clear cell kidney cancer has altered dramatically. We use combinations of checkpoint inhibitors, nivolumab plus ipilimumab, as Dr. McDermott mentioned, in the treatment of some patients with advanced clear cell kidney cancer, but also used widely combinations of immune checkpoint inhibitors and the very same targets that agents that target consequences of VHL inactivation. Axitinib, for instance, cabozantinib is another agent that's been combined successfully with immune checkpoint inhibitors. Lenvatinib is a third agent that is commonly used in combination with immune checkpoint inhibitors in the management of patients with advanced clear cell kidney cancer. While understanding the VHL pathway has really helped us more effectively treat patients with advanced sporadic forms of clear cell kidney cancer, we asked how we can utilize that information to treat patients with VHL disease, a condition that urologists are a lot more familiar with than medical oncologists. VHL disease needs no introduction to most of you. As you know, it's a multi-system cancer disorder, predisposing patients to develop tumors in multiple organ systems, including bilateral multifocal clear cell RCC. The story begins in the early 80s when Marston Linehan, Bert Zabar, and others at the NCI decided that they needed to try and understand why patients with VHL get these cancers. And so they collected families with the syndrome and very carefully studied them to identify a gene called the VHL gene located on chromosome 3 that seemed to be altered in the germline of these affected patients. We now know that the very same gene is altered by somatic mutations in patients with sporadic forms of clear cell kidney cancer. It took another 15 years or so to fully understand how loss of the VHL gene leads to kidney cancer. A lot of work done both in Dr. Linehan's lab, labs of these gentlemen who won the a Nobel Prize for Medicine and Physiology in 2019, and a number of other labs who I can't really mention in this short talk, really allowed us to understand that hypoxia or pseudohypoxia is a key element mediating VHL-dependent kidney cancer. And that is what led to all the efforts I've talked about so far that effectively target alterations in this pathway. So why should we even be looking at systemic therapy for patients with VHL? How do we manage patients with VHL? You heard a little bit about this from Dr. Linehan and Dr. Ball. The goals of treating patients with VHL are twofold. One is to minimize the risk of metastasis, and this is applicable to those tumors which have metastatic potential, kidney cancer, pancreatic neuroendocrine tumors, pheochromocytoma. But we also treat patients with tumors with a view to controlling local symptoms or systemic complications. Once metastatic, we don't really know how to treat these patients, and we treat them the way we would sporadic counterparts of the respective histologic subtypes. While these treatments have been very effective, and we have managed to treat patients with VHL quite effectively with surgical techniques, any of you who's treated VHL knows that these surgical approaches are associated with significant comorbidities because you often have to repeat surgeries multiple times during a patient's lifetime with all the morbidities those procedures incur. So there's a real need to develop therapies that may give patients a break from surgery, or at least minimize the number of surgeries they may have to go through in their lifetime. And that is why we and others became interested in developing systemic therapies for these patients. An ideal systemic therapy would be able to achieve a lot of the things that surgery does. So prevent tumor growth, prevent the potentially onset of new tumors, which surgery can't necessarily do, minimize the risk of metastasis, but also provide a quality of life that's acceptable and allow these patients to go about their business as normally as possible. Initial attempts to treat these patients with systemic therapy utilized VEGF-targeted agents. Several trials are listed here. And I'll quickly summarize what we saw with those trials using these two drugs and studies as an example. We saw some activity, particularly in renal tumors associated with VHL, when we treated patients with vandetanib, pazopanib, sunitinib, and other agents in this category. We didn't see a whole lot of activity in non-renal tumors, but what we did see a lot of was side effects. Many of these patients were unwilling to accept the side effects that patients with metastatic kidney cancer who had very limited alternatives were willing to accept. So as a result, most patients went on study and off study fairly quickly. And so this was not really a long-term viable option. Of course, what we'd have really liked to do was target HIF2, which we know is a very key driver of kidney cancer in the VHL deficient setting. This is a very difficult target to drug, and it took a couple of decades of efforts to really nail down a method to try and target target HIF with small molecules. And the result was a class of agents, small molecules, that was able to effectively disrupt the formation of a heterodimer of HIF2 and HIF2 alpha and HIF1 beta, a heterodimerization that's essential for function of this transcription factor. The first agent in this category was called PT2385, and we at the NCI did a very small proof of concept study looking at this agent in patients with VHL-associated renal tumors. Very early on in the study, it became very clear that this drug was different. The tolerability profile was much better than what we saw with VEGF-targeted agents, and we also saw very ready regression of tumors in the kidney, in pancreatic neuroendocrine tumors, CNS hemangioblastomas, and even eye angiomas. So we were very, very excited. But there were some pharmacokinetic limitations to this particular drug, which fortunately the scientists at Peloton, the company that developed these drugs, was able to overcome by developing a second-generation HIF2 alpha inhibitor called belzutifan, also known by various other names listed here. So we then took this drug in collaboration with a number of other VHL experts around the world and with Peloton and Merck, and designed a multi-center global study to evaluate the efficacy of this drug in patients with VHL-associated RCC. The primary endpoint of the study was overall response rate in kidney tumors, but we also looked very carefully at toxicity of this agent, as well as responses in non-renal lesions. We enrolled a total of 61 patients. The trial accrued fairly rapidly, which was surprising to us, but also gratifying because this is a relatively rare condition. The patient demographics were very typical of what you would expect for this group of patients. But in addition to kidney cancer, all patients had at least one pancreatic lesion, including 22 patients who had a pancreatic neuroendocrine tumor. 50 patients had a central nervous system hemangioblastoma, and 16 had evidence of a retinal hemangioblastoma that we could follow on study. The overall response rate in renal tumors in this study with this agent was close to 50%. These responses, at least at the time of this analysis, were all partial responses, so we were not curing patients, which is a difficult bar, as you know, because you're never really going to change the germline alterations and the predisposition to tumors. But we were very, very happy to see that half the patients had objective RECIST-defined partial responses. When you actually looked at how many patients had regression in their tumors, much larger proportion, 92% had some degree of tumor regression. Knowing what we do about the way this particular class of drugs work, it is very likely that we'll see the response rates increasing overall. But what's key here is that a very, very overwhelming majority of patients did develop or did exhibit tumor regression. This graph illustrates how we managed to alter the natural history of these tumors. On the left side, you will see the growth curves of these tumors that we had very, very carefully followed pre-treatment for years on many of these patients. And the natural history is one of inexorable growth in the absence of intervention. So the intervention usually, until the study, was surgery, which would occur when the predefined criteria were met. But you can see when we introduced belzutifan, the vast majority of tumors either didn't grow at the same rate, or many of them actually started regressing. We talked a little bit about durable responses when Dr. McDermott was up here on the podium a few minutes ago. At least as of now, the responses with this agent seem very, very durable. At the time of this analysis, with a median follow-up of around 2 years, 89% of the patients remained on study. And as you can see from the swimmer's plot, most of them had ongoing clinical benefit. I'm going to show you a couple of cases of the kind of patients we treated on this study and why this drug's likely to make a really significant impact on how we treat this group of patients. The first is a 45-year-old woman who was diagnosed at the age of 34 with VHL when a left-sided renal tumor was identified. She underwent a partial nephrectomy and will continue to be surveyed subsequently. When she came to us, she was very desirous of avoiding additional surgical procedures. Came to us with bilateral renal tumors, the largest of which was around 2.6 centimeters, so heading towards surgery. She also had a couple of pancreatic neuroendocrine tumors and some CNS hemangioblastomas. Shown here is a fairly large, close to the hilum, renal tumor on the left kidney and a couple of renal tumors on the right kidney, all of which very, very clearly and rapidly regressed following initiation of belzutifan. So clearly at this point in time, this patient does not need surgery. At worst, we have set the clock back by several years. So it's unlikely that this patient would need surgery as quickly as she would have in the absence of this intervention. We're also seeing very impressive responses in non-renal lesions. In pancreatic tumors, we see an overall response of 77%, including regression in 90% of patients with pancreatic neuroendocrine tumors. And around a third of patients with CNS hemangioblastomas have very clearly demonstrated regression. These tumors are a little harder to follow, and I suspect the true response rate is probably a little higher, but this is what we found in the study. I'm going to show you a second case here of a 30-year-old man diagnosed with VHL at the age of 12. Very, very difficult life for somebody who gets diagnosed at that early age with tumors everywhere. I mean, he had tumors in every organ you can conceive. Over the years, he had to undergo multiple laser and cryoablations of retinal hemangioblastomas and had bilateral vitrectomies. He's had no less than 7 surgeries to facilitate resections of hemangioblastomas in the CNS. So you can imagine the impact these procedures have had on the quality of life of this patient. He came to us with bilateral multifocal RCC that were heading towards a surgical threshold and new multiple cerebellar and CNS hemangioblastomas. On the top panel, we show you 2 hemangioblastomas, one in the thoracic spine and one in the left cerebellum. We work very closely with Dr. Prashant Chittiboyna and Dr. Karim Zaghloul, neurosurgeons at the NIH, in the management of these patients. And I'm glad to say, at least in this case, Dr. Chittiboyna's services will not be needed. You see very, very clear regression in both the tumors illustrated on this slide. Ocular lesions contribute significantly to the morbidity of patients with VHL. Many patients go blind. The patient I presented previously was blind in both eyes because of multiple retinal hemangioblastomas. For the first time, our ophthalmologists, Dr. Stu and Henry Wiley, who work very, very closely with us in the management of these patients, told us that they've seen impressive regressions of hemangioblastomas in the eye with a systemic agent. So far, there's nothing they've tried that's worked, but we see very, very predictable, very impressive regressions in hemangioblastomas with this drug. So one of the key goals of developing a drug like this would be to try and delay the need for surgery or obviate the need for surgery altogether. And this graph illustrates a little bit of what we've achieved on that front with this drug. To the left of the solid black perpendicular vertical line that you see are the black dots that indicate surgical procedures in patients with VHL before belzutifan, before they receive belzutifan. And you can see a number of black dots, so these number into the hundreds over the last several years. In fact, if you just look at the preceding 2 years, which is approximately the length of follow-up we have on therapy for these patients, you still see several procedures that these patients have had to undergo. Following initiation of belzutifan, we only had 3 procedures that were needed in these patients. So short follow-up, but early indications are that we may actually be impacting how we manage these patients and minimizing the need for surgery in these patients. I also said that it would be good to have a drug that was well tolerated, and this drug fits the bill, certainly far better than the VEGF-targeted agents do. While most patients had side effects, most of the side effects were mild and manageable. The most common and very predictable side effect, because it follows from the biology of HIF2 and how this drug targets that pathway, was anemia. Anemia is mostly seen a few weeks after we initiated therapy and tended to stabilize over time. Most patients could be managed very effectively without a need for stopping or discontinuing the drug. Patients were managed either expectantly or occasionally with erythropoietin and even more rarely with blood transfusions. So most other side effects were very, very mild, fatigue being chief amongst them. But most patients were able to lead a lifestyle comparable to what they had before they initiated therapy. As you're probably aware, these data were recently presented in the New England Journal of Medicine. As you're probably also aware, these data led in August of 2021 to the approval of this agent for patients with organ-confined tumors associated with VHL. So as a result of these developments, we now have an FDA-approved systemic therapy for the management of VHL-associated tumors for the first time. And clinical implications of this approval are that some VHL patients can now be managed medically. And I emphasize the word some because I think we have to be very careful about whom we treat and how we treat them. I look at this agent as being a complement for conventional management strategies like surgery and cryoablation and so on and so forth. And I do believe that in the long run, you will see a lot of patients avoid or delay surgery as a result of this treatment and treatments like this. I will also emphasize that while it's tempting to have everybody who has access to this drug treat patients with VHL with this drug, care of the VHL patient is still very difficult and requires a very dedicated and experienced multidisciplinary team. We still have a lot to learn, but I think this is a very promising beginning in treating VHL patients. This drug has also shown efficacy in patients with advanced metastatic sporadic clear cell kidney cancer, and shown here is a waterfall plot from a study Dr. Shueri conducted. It's a phase 1-2 study of this agent showing promising activity, which has led to the development of randomized phase 3 study in previously treated patients with metastatic kidney cancer. Patients are randomized to this drug versus everolimus. The trial has completed accrual, and we're waiting to read out the data. So I think we can learn from the foregoing slides that understanding the VHL pathway has allowed us to effectively intervene in patients with both sporadic forms of clear cell kidney cancer and VHL-associated tumors. A number of other HIF2 alpha inhibitors are now in early clinical development, and we and others are trying to figure out how best to improve upon the benefits of HIF2 alpha inhibitors that we've gleaned so far from the studies I just presented. I'm going to spend the next few minutes talking about papillary kidney cancer, which is the second most common form of kidney cancer. Until recently, there were no effective forms of treatment for this entity, or this group of entities, I must say, as I'll point out in a minute or two. The first dedicated papillary kidney cancer study to show a clear benefit for any intervention was this study called the PAPMED study, led by Dr. Samantha Paul and others, which showed a superiority for cabozantinib versus sunitinib in patients with metastatic papillary kidney cancer. Unfortunately, the median PFS was only 9 months and the overall response rate only 23%. We and others are hopeful that by understanding the biology of these tumors better, we may actually be able to improve these numbers. And I'll show you a couple of examples of how we may do that. We know that cabozantinib is a MET as well as a VEGFR inhibitor. Going back a few years, we and others conducted a study with another similar agent called furetinib, which was the first-in-class MET inhibitor evaluated in patients with kidney cancer. It also had VEGF target. It also could target VEGFR, as shown here. Several people that are involved with the treatment of papillary kidney cancer, Dr. Shueri, Dr. McDermott, were all involved with the study. And what we learned from the study was that just as with the PAPMED study, not a lot of patients benefited from this study if you took all comers with papillary kidney cancer. However, if you look at patients with germline MET alterations, really the population which you would expect most to benefit from a MET inhibitor, you saw a much higher response rate, a response rate of 50%. Small numbers, but regardless, high response rate. While if you didn't have a MET alteration, your response rate is only 9%. So early indications that if you had a MET mutation, you might do much better with a MET inhibitor. Other studies, again small studies, have confirmed this observation. There's a study from Europe looking at crizotinib. We have a study with cabozantinib, which has shown very, very similar results and extended the data that we generated with this study. More recently, investigators at the Memorial Sloan Kettering Cancer Center have looked at cabozantinib in combination with nivolumab and are starting to show some promising activity in patients with papillary kidney cancer. We still need to figure out who are most likely to benefit from this approach. They present some early molecular data that suggests that some subgroups may benefit from this approach more than others, and it's these kinds of studies that we really need to move the field forward. The story with papillary kidney cancer, however, is a lot more complex than some of the aforementioned studies suggest. Papillary kidney cancer is a very heterogeneous group of malignancies. It's not one entity. Just as we say kidney cancer is not one entity, papillary kidney cancer is not one entity. Type 1 papillary kidney cancer is a relatively homogeneous group of malignancies based on both the molecular changes underlying this entity and the histologic parameters that characterize this subtype of cancer. However, the entity that we've traditionally called type 2, that we like to refer to now as non-type 1 papillary kidney cancer, is really a lot more diverse, and a variety of different subtypes with in a diverse array of alterations have been identified. And we've worked on this very, very closely with our wonderful pathologist, Dr. Maria Marina, who's been telling us for years, don't treat all papillary kidney cancers the same. And she was right, because when we looked at the molecular profiles underlying these tumors through the TCGA analysis, we found that there were at least 4 distinct subtypes of kidney cancer, and these molecular subtypes segregated with outcomes as well. I'm going to focus today on one particular entity, hereditary leiomyomatosis and renal cell cancer. I won't go much into the clinical description of this entity because Dr. Linehan already did. But suffice it to say that this is an entity that occurs because of inactivating mutations in the fumarate hydratase gene and the germline. These patients have a very aggressive form of papillary kidney cancer, and until recently there were no data from prospective studies to guide therapy, and most of these patients died very quickly after diagnosis of metastatic disease. By understanding the pathway that led to kidney cancer following loss of fumarate hydratase, we were able to come up with a strategy to target effectively what we thought were key aspects driving this tumor. And we used a combination of bevacizumab and erlotinib, a VEGF-targeted antibody, and an EGF receptor inhibitor to try and see if this combination would be effective in this tumor. We conducted a phase 2 study looking at both patients with HLR-CC and sporadic papillary kidney cancer, because some of those patients share some characteristics with HLR-CC patients. 2 independent cohorts treated identically with bevacizumab and erlotinib. I'll skip over this slide, and what we saw was that in the HLR-CC group, the overall response rate with this combination was 72%. Mind you, this is a group that was not very responsive to treatments previously, so treatments that were typically effective in that era in patients with advanced clear cell kidney cancer didn't do much for these patients. And many of the patients who came onto the study were actually treated with those agents like sunitinib and pazopanib. So we were quite happy to see a fairly high response rate. We also noticed that the vast majority of patients who went on the study developed some degree of tumor regression. Once again, durability is a key question, and patients treated with this regimen had durable responses. At the time of this analysis, the median duration of response was 19.3 months, and several patients after 5-6 years still remain on the study in remission. The median PFS is 21.1 months. This in a disease where before these treatments became available, the overall survival was somewhere in the 12 months to 16-month range. A couple of examples of the kind of patients we treated and saw some nice results with on this trial. First is a 58-year-old man who presented with left flank pain, underwent a radical nephrectomy with lymph node dissection for a large tumor. The histology was consistent with a type 2 papillary kidney cancer, and germline testing revealed a pathogenic FH alteration. He developed metastatic disease soon after his kidney primary resection, and came to us with extensive retroperitoneal adenopathy as well as some mediastinal adenopathy, tumor deposits in the psoas, so fair amount of disease. Following initiation of treatment, very rapid response in most of these areas. After following 4 months of therapy, very, very little disease, as you can see, left. The patient stayed on study for more than 18 months and eventually progressed. A second case, 33-year-old woman, again with a diagnosis of HLR-CC with extensive hepatic mets, treated again with this regimen. You can see how significant the regression has been and how durable the regression has been. Shown here on the right side are the regression of the hepatic mets 2 years following initiation of therapy. Patient remained on therapy for up to close to 4 years before eventually progressing. We made some gains in treating this condition, but we want to do more. We're not curing a lot of patients, even though we see some durable responses. And with a view to expanding on the gains we've made with this regimen, we've opened a new study which combines this doublet with atezolizumab, a PD-L1 inhibitor, to try and see if we can improve on the results we have with this combination. So I'll end there by saying that while papillary RCC is a very heterogeneous group of malignancies, by understanding the distinct molecular pathways that drive individual subtypes of papillary kidney cancer, we've started to make some headway in effectively treating at least some of these types. And we and others continuing our laboratory efforts to try and expand this to other forms of papillary kidney cancer where we haven't been able to make the same kind of gains as the ones in which we've discussed so far. Last but not the least, we have a large group of people aiding in this effort, both within and outside the NCI. And without this very talented and committed group of individuals, we'd never make the kind of progress we have. Thank you, and I'll stop there.
Thank you very much, Dr. Srinivasan. I mean, I'm completely blown away by the science behind all this and by the advances that we've seen. And you've heard this morning. I don't know, it makes my knees weak to think about. You heard this morning from Dr. McDermott some complete responses in patients with advanced disease. We didn't have anything before. And you heard from Dr. Srinivasan some dramatic response, some complete responses in patients with papillary, which was considered horrible and untreatable, sort of. And you also heard from Dr. Srinivasan, don't forget this, you heard from Dr. Srinivasan also in VHL, this is the first hit, responses in kidney. Right? Responses in kidney. We think of surgically, all right? I think this is just the beginning. He also showed you the MET, the hereditary papillary. There, he showed you, it's kind of buried in a slide, but there, responses in kidney tumors in patients with that type of kidney cancer, papillary, with that gene MET there. Now, we're not home yet. They're not, complete responses and making them completely go away. But the first evidence that you could really treat tumors even in the kidney. So I think as urologic surgeons, we got a lot to think about here, but I think we're getting a lot of help from our colleagues working on understanding how these tumors work and working on developing these therapies. So are you all going to be able to pull up my slides again? While they're doing, mine was the first talk. I think just for the follow-up questions, if we can do it, we will. If we want, it's fine. So let me go back, though, to a surgical question. Dr. Ball, you showed us some remarkable advances surgically in managing these. I know you can do almost anything robotic, but here we are in 2022. When we're doing those cases, I mean, for example, old days, we used to clamp and slush, So when do you clamp today? You can do anything, but when do you clamp? And also, when you just say, look, it's safer, let's just take this kidney out. Two questions.
Good questions and tough questions in many ways. I think there are two main reasons to clamp. One is to prevent hemorrhage, but two is to be able to visualize your tumor and resection plane and have a good oncologic result. And certainly for a deep tumor, one that's abutting the sinus, I almost always clamp to prevent the first, but then able to make sure I have a good margin because you can see, it's particularly deep, sometimes tumors are not perfectly round, they can have lumps or bumps, and if you leave a piece of tumor behind, then you've not done the patient any good. And then the second, the AUA guidelines have really laid out pretty well when we can think about radical nephrectomy. If a patient is going to have has a higher oncologic risk tumor and is predicted to have a GFR of over 45, then that's a patient where radical is on the table, and we can certainly think about that. And while we certainly underutilize partial nephrectomy in some places, among cancer centers and tertiary centers, we may be overutilized rather than underutilized partial nephrectomy. So those are some of my thoughts.
Okay. All right. Well, in other words, be safe than sorry. We want to save kidneys, but we don't want to save the cancer and have it come back and bite them. So living to fight another day with one kidney is better than developing metastatic disease. So we're pretty conservative on that. Yeah.
Dr. Ball, you presented a case of bilateral tumors. One side was chromophobe, the other side was RCC, a clear cell. You opted to go for an enucleation and then wide excision. Given the high concordance, histological concordance of 90% for synchronous bilateral tumors, how frequently do you do a bilateral biopsy?
That's a really good question.
Fantastic question. You know, I think we can't take for granted if just because we see something on one side that it's the same thing on the other. So I will often utilize biopsy, again, when it's going to change management. If we take out a tumor that's an oncocytoma on the other side, you know, I'm on one side, I'm probably going to biopsy the other, because if it's oncocytoma, that's going to change management. I may not offer that patient any treatment and do active surveillance. Or if it's a deep tumor that maybe is a radical, I'm going to biopsy that tumor, same as if it were presenting with one tumor and one kidney. When it's really going to change management is when I utilize it.
We always say, we have sort of a thing at our place that, you don't second guess the general in the field. In other words, the surgeon doing the case. And so, as Dr. Ball would say, we've had people with bilateral multifocal onco, but we're not so sure. We make sure. We had one recently that was onco on one side, onco clear on the other, and that clear just about bit us. It got deep, and it got into the renal vein. We got it out, guys, done fine so far, but whoo, that was the surgeon managing the patient said, I'm worried about that. I'm not sure about that. Now, we'll do cystamibi. Dr. Ball would say, he showed that cystamibi sometimes helps us, but even that, we're a little careful about. Dr. Srinivasan, just in the last minute here, you talked about this miracle drug, this incredible thing with belzutifan. I got a couple patients here real quick. I got a 22-year-old, so our urologic surgeons here, they're seeing a 22-year-old with this disorder, got a 2-centimeter mass in the kidney. She's not had any surgery. 2 centimeter. Treat them, watch them. We wouldn't do surgery because it's not 3, but what do you think? I got 2 patients. And then I got a 44-year-old who's also got a 2 centimeter. He's had 2 surgeries already, okay? His renal function's a little down, not much, a little bit. And, he doesn't want more surgery, okay? Those 2 patients, real quick, in closing.
So assuming there isn't any other overriding reason to treat this patient, like a symptomatic hemangioblastoma or near symptomatic hemangioblastoma in the spine or some other reason, assuming the decision is going to be driven by what we see in the kidney, I might be inclined to watch the 23-year-old a little longer, because I think there's a shelf life to these agents. I'm not sure that we can treat them for life with this agent.
Right.
My fear is that eventually you'll develop some resistance, although I don't know that at this point. So I'd be very judicious in offering somebody who may not need it right away. It may take years for her to get to close to 3 centimeters. I may offer it closer to the time she's reaching 3 centimeters. On the other hand, if somebody has already had 2 surgeries and we want to avoid a 3rd surgery at any cost, and they have a tumor that's heading towards the surgical threshold, I may be a lot more inclined to offer that person this drug.
So I presume the consensus of the group up here also would be, we've kind of got a lot to learn. We have a wonderful tool. We're thrilled about it. It's approved by the FDA, as Dr. Srinivasan said, based on this wonderful trial. And, of course, you got to think about the other things with those VHL people. Not that common, but when you do see them, the brain you treat also, and the pancreas. So I have to think together on that. But anyway, we're at the 12 o'clock hour, and I want to really thank my colleagues here that made so many contributions to this field. We're so thrilled that they came. Thank you, Dr. McDermott. Thank you, Dr. Srinivasan. Thank you, Dr. Ball, for coming. We really appreciate it. I know I learned a lot, and if the audience learned as much as I did, then it was a great session. Thank you very much.
Thank you.